I have topic allotted to me is types of PDE5 inhibitors. What are the new PDE5 inhibitor and they are superior? But we all know it, the PDE5 inhibitor is accidentally PDE5 inhibitor are accidentally invented during the investigation or for the management of hypertension and angina. And it is estimated that there are 320 million cases will be by 2025. On the basis of the, I have divided two groups, PDE5 inhibitor on the basis of the FDA approved and non-FDA approved. FDA approved are Signafil, Varnafil, Tadalafil and Avnafil, and non-FDA approved is Lornafil, Udinafil and Muradinafil. These are the 7 types of the PDE5 inhibitors are available. Now, on the action, there should be, it is approved for action, FDA approved for the action. Signafil, Tadalafil is approved for the pulmonary arterial hypertension. Tadalafil approved for the lower urinary tract symptoms, and all the 4 drugs, Signafil, Varnafil, and Avnafil, Tadalafil, are approved for the erectile dysfunction. But they are yet not approved for the other applications: obesity, cancer, cardiovascular disease, neurological disorder, diabetes, and COVID-19. First, we all know first Signafil launched in 1998. It concerns the dose of the 25 milligram, 50 milligram, 100 milligram, and it is advised it will be taken from the half hour to 1 hour before the sexual activity. Maximum frequency is once per day, and it may be taken as empty stomach. There. And next is Varnafil. Dose comes with 2.5 milligram, 5 milligram, 10 milligram, 20 milligram, and most patients start at 10 milligram taken 1 hour before the sexual activity. High fat meal can reduce the plasma concentration by 18 to 50. So it will not be given with the fatty foods, the foods which have high fat. Tadalafil, we also after the Signafil, the Tadalafil come in the market in India. Doses are 5 milligram, 10 milligram, and 20 comes in the. Most patients start 10 milligram and it taken without regard to food. Can be taken any time, whether it is empty stomach or the with food. Maximum frequency is 1 day, and it lasts the maximum duration of action up to 36 hours. Next is Avnafil. This is the 4th PDE5 release in the market. Potential advantages include it can take it closer to the time of sexual activity. Sometimes it can be taken 15 to minute prior to sexual activity, or easily contracted by the 30 minutes prior to sexual activity. They have the Avnafil have the side effect, adverse effect. They have the less visual disturbance than the Signafil and Varnafil, and it has the quickest action reached up to maximum in 1 hour. Considering the recent market history, comparative trial, it has similar efficacy and safety consideration as the other 3 major PDE5 inhibitors. Next is non-FDA approved PDE5 inhibitors are the Lornafil, sexual activity and alcohol. It can be recommended which PDE5 inhibitor taken with the alcohol consumption. Lornafil can be taken as with the alcohol. Silva AC et al. Conducted a controlled clinical trial on the 15 patients divided in 2 groups and received Lornafil carbonate in fasting with alcohol. And they conclude there no adverse effect is noted in terms of the blood pressure, heart rate, and the QT interval. There is no prolongation of the QT interval. Next is the non-active mirabinafil. It is approved only in Korea. Second generation, launched in the 2007. It comes 100 milligram. It is very much costlier, and it available in India only in online. Mirabinafil appeared to be 10 times more selective to PDE5 inhibitor as sildenafil. It is a biochemical profile as such high affinity to PDE5 and the selectivity for PDE5 over the PDE5 isomers compared to the other existing CDO, sildenafil, vardenafil, and tadalafil. So mirabinafil is there. PDE5 isomers are present every in the like in the retina, gut, they are present. So their cross mechanism action occurs. So it have the minimum effect with the PDE isomers. Then over the sildenafil, vardenafil, and tadalafil. It appears to be effective, safe, and well tolerated in men with both ED and hypertension, and lower urinary tract symptoms, and BPS, benign hypostatic hypertrophy, who are concomitant hypertensive and medication or alpha-1 blocker. A multi-center randomized double-blind placebo-controlled parallel group dose study was conducted with 112 subjects who were randomized to either metafil 100 milligram or 12 weeks. It shows that mirabinafil group showed significantly greater improvement in sexual life and partner relationship than the placebo group. Most treatment associated adverse effects are mild and that resolve responders. Next is sildenafil, developed by Korean pharmaceutical company in 2005, available in 100 milligram, 200 milligram formulation. Sildenafil has the unique properties such as relatively rapid onset and long duration action, 11 to 13 hours. Both on demand and once daily use can be reported. Sildenafil efficacy and tolerability have been evaluated in several studies. Recent and continuous have demonstrated sildenafil provides in cost approximately 125 milligram per tablet of 100 milligram. Sildenafil was significantly effective for the treatment of ED, demonstrating statistically significant improvement in the erectile function in patients with diabetes mellitus. The incidence of adverse event was relatively low and well tolerated in diabetes mellitus. The new PDE5 inhibitor they are superior. I have this. Key characteristic of PDE5 compared with the 4 FDA approved PDE5 inhibitor, the sildenafil, tadalafil, vardenafil, abnafil. We all know the sildenafil approved for the by FDA in 1998, tadalafil and vardenafil in 2003, and abnafil in 2012. The usual doses 25 to 100 milligram, and tadalafil 5 to 20 milligram, vardenafil 5 to 20 milligram, and abnafil 50 to 200 milligram per day. Then it is administered sildenafil and the vardenafil 1 hour before or prior to sexual activity, and tadalafil and the abnafil 30 minutes prior to sexual activity. The efficacy, sildenafil and vardenafil have almost same duration of action. Sildenafil half an hour to 4 hours, and the vardenafil is about 5 to 7 hours of post-dose, and the maximum duration of action 36 hours of the post-dose, and the minimum action is 0.25 hours of the post-dose. If the concentration increase with the fatty acid, and the tadalafil have no effect. In vardenafil, the concentration is decreased, and abnafil also the concentration increase with the food. Then in all the PDE5 inhibitor cleared by the renal. So if the creatinine clearance is below the 30 ml per minute, so it is sildenafil used cautiously in minimum dose about 25 milligram per day. And tadalafil, if the creatinine clearances 30 to 50 ml per minute, then start the dose of 5 milligram and maximum 10 milligram per 48 hours. If the person is suffering with hemodialysis and creatinine clearances more than 30 milligram, then it is 5 milligram per 72 hours and once daily dose. If the creatinine clearances 30 ml per hour, please do not use this drug. And varnafil should not be used person who have on the hemodialysis. And also the abnafil also do not use if creatinine clearances below the 30 ml per minute or person is having on hemodialysis. First, abnafil and the varnafil are have more cost than the sildenafil and tadalafil. So if we compare the adverse effect of the abnafil and tadalafil sildenafil, vision chaser or color blind not seen with the abnafil and tadalafil, respiratory action not seen with the tadalafil, other adverse effects are seen in all the three drugs like rashes, dizziness, headache, and back pain, diarrhea, and flushing. We can say on the term of the in terms of the side effect or the adverse effect, abnafil and sildenafil is superior than the sildenafil. Sildenafil is a drug that people use only when they need it. A person takes the drug 30 minutes to 1 hour before sexual activity, and the effect typically lasts for 3 to 5 hours. And varnafil may start working faster than the sildenafil, but it lasts for about the same amount of time. The effect of similar dose of tadalafil may last up to 36 hours. For this reason, people looking for a long-lasting drug may choose the tadalafil. Depending on the dose, abnafil will be effective after 15 to 30 minutes, and so it is effective for up to 6 hours. This chart shows the comparative chart of the sildenafil and tadalafil. Here, so the patient disposition and reason why that is in which drug discontinuation is more. Here, this study shows the discontinuation is higher with the sildenafil than the tadalafil. This study shows the IEF, the erectile function, organic function, sexual desire, intercourse, overall satisfaction. The overall satisfaction is more with the tadalafil. It is 95% confidence interval. Abnafil has been shown to have similar efficacy and safety consideration as other three major PDE5 inhibitors. A unique benefit abnafil has the quick onset of action. Cost is important consideration with abnafil because of the impending availability of generic PDE5 inhibitor. A study found that switchback rate is less than 10% in the sildenafil and varnafil cohort, and it is 25% for tadalafil. The person who they are taking the sildenafil and varnafil, they switch to other PDE5 inhibitor. They factor in terms of the switchback rate, tadalafil is better than the sildenafil and the varnafil. Factor which may be attributed to this preference of tadalafil or sildenafil and varnafil include longer duration of action, more spontaneity in the sexual activity. Tadalafil may be taken with fatty acid without disturbing bioavailability. In a study, 16% of intercourse attempt with sildenafil successful if it is taken, and only 8% were successful with the placebo group. Sildenafil given 60 minutes prior to sexual activity had been achieving an erection that led to successful intercourse 35% as compared to 22% in placebo group. In another study, sildenafil given within 20 minutes resulted in successful intercourse in 51% as compared to 30% placebo group. Varnafil also have the same effect as the sildenafil. Varnafil and tadalafil were found superior in subdomain of self-confidence and spontaneity. Patients were likely to provide a higher rating in concept of these subdomains than the patients who were taking sildenafil. Sildenafil, Moon and colleague reported that IEF and EFT score at baseline were significantly improved in both Udnafil 100 mg and 200 mg group, with improvement by the 7-8 points, respectively at 12 weeks compared with the placebo. Udnafil was significantly effective for the treatment with ED person who are suffering from diabetes mellitus and the ED. The incidence adverse effect relatively low and well tolerated in patients with diabetes mellitus. This is the study, the efficacy of the Udnafil dysfunction is compared with the here the Moon et al. In 2011, Pak et al. In 2009, and Chung et al. In 2000. They have studied taken the patient suffering with diabetes mellitus and the hypertension and BPH and lower urinary symptoms. They have found us significant. There no adverse effect is noted. Udnafil drug was well tolerated. Adverse reactions were mild and self-limited and included the headache, tinnitus, flushing, color visual disorder, and dyspepsia. Dose of 80 mg of Udnafil carbonate was significantly more efficacious than the placebo and well tolerated. It is least studied drug. Now I compare with the Mirodinafil and other phosphodiesterase 5' inhibitor in patients with the diabetes and erectile function. Here the Mirodinafil have the superior than the Sildenafil, Vardenafil, and Tadalafil in both IEF and EF domain and global assessment questionnaire. In this item, the IEF and EF domain, the comparison of efficacy of parameter between middle and other patient with economy taking the antihypertensive drug. The person who are taking here is also Midafil is slide shows the Midafil superior than the Sildenafil and Tadalafil. The overall satisfaction in global assessment question, Mirodinafil have the 84 and Sildenafil 80, Vardenafil 80 and 87. So in the global assessment questionnaire, the Tadalafil is superior than the Mirodinafil, Sildenafil and Vardenafil. So here I would like to conclude all the available PDE5 inhibitor have more or less same effect. So all approved selective PDE5 inhibitor efficacious and lead to improved erectile function in sexual encounters. Choice of drug and intervention should be based on patient preference, side effect profile, presence of or concurrent lower urinary symptom, and the desired half-life. Choice of the specific period should be directly by depth of conversation between provider and the patient. Going forward, studies that compare the efficacy and side effect among all the approved PDE5 inhibitor should shed significant light on the developing a treatment allowed to. Thank you, sir.